All right, hello and welcome everyone to another MMS info session. As you know, these sessions are offered under the CMS Measures Management System contract, which is led by Battelle. I'm Brenna Rabel and I oversee education and outreach on this project. So today's session is all about race and ethnicity data, specifically a new method developed by RAND to improve measurement of race and ethnicity in CMS data to better inform efforts to understand inequities in the quality of care. You'll be hearing from Dr. Mark Elliott from the RAND Corporation and several members of the CMS team overseeing this work. Next slide, please. So as you know by now, these info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics. That's an effort that also includes a series of newsletters and bulletins, along with special announcement emails, public webinars, and routine updates to the Measures Management System website. We do these sessions on a monthly basis so that we can continue to provide up-to-date information on a wide range of topics related to quality measure development like this one. So before we jump into the presentation today, I just want to cover a couple of housekeeping items. The first is that today's session is being recorded. Second, all participants will be muted during the call. We will have an opportunity for Q&A at the end, during which we encourage you to enter your questions into the Q&A feature. You can enter your questions at any point during the call, but we'll be getting to them at the end. And then finally, the presentation slides from today's session are going to be posted to the MMS website for your reference, and the recording of today's presentation will be posted to the CMS YouTube page on a later date. Next slide. All right, and before I hand the presentation over to Dr. Elliott, I just wanted to provide a little bit of context here. So this topic is especially timely and important given the increased emphasis at CMS in understanding differences in measured performance by race and ethnicity. And one barrier to doing this is the prevalence of missing data in race ethnicity fields in the medical record. So today's presentation describes one particularly promising approach for addressing that challenge. So we've asked the RAND team to share their work in this area for informational purposes, but I just wanted to say up front that CMS hasn't formally adopted this methodology across programs. But having said that, I'll hand this over to Dr. Elliott to talk us through. So next slide.
Thanks very much. So just to describe thanks for the opportunity to speak to you, and wanted to start by describing the objectives of the presentation. I'm going to describe a new methodology regarding missing race and ethnicity data. It's one that can be used to take the administrative data that's already in place for Medicare data and use it to do various things like comparing HEDIS clinical quality data by race and ethnicity, and I'll describe a number of applications, mainly as examples to help you think about other things that might be done. So we'll look at measuring differences in voluntary disenrollment rates for Medicare plans, and trying to figure out who does and doesn't respond to items about race and ethnicity on a CMS survey. Also, talk about an application to a health equity summary score that's meant to incentivize good care for underserved beneficiaries. Also talk about ways that you can present stratified information about the performance of health plans for different racial and ethnic groups. And also we'll describe some work about inequities in behavioral health care. Next slide, please. So a little bit about the motivation for this work. So race and ethnicity data, as is widely recognized, are essential to make sure that quality, coverage, cost, and access proceed equitably. And a lot of the first mandates to collect this information federally came from the Affordable Care Act. In everything that we do, we view the gold standard as being what somebody reports about their own race and ethnicity. And whenever that's available, we always prefer that. But in some cases, that's not available in the form that you'd like. So in some cases, the information is missing. In other cases, you have an administrative variable that's incomplete or offered people constrained choices that doesn't allow them to self-report the way that they like, and these can limit people's ability to assess the functioning of the healthcare system. And in this, I'm going to describe two related methods that we've developed to address missing race and ethnicity data or to improve existing administrative data. One that's meant for more general context and one that's more customized to the Medicare context. Next slide, please. So these two methods are the BISG and the MBISG method. The M stands for Medicare. The starting idea for these methods is that there's a lot of information in people's names and where they live that can be used to help improve information about race and ethnicity. And the other thing that's helpful about these, variables is that a wide variety of data sets have name and address. So the most basic form is what we call the Bayesian improved surname and geocoding approach, and that approach only requires name and address data linkable to whatever you're trying to compare. And so any data set with name and address data, you can compare racial and ethnic groups. The Medicare BISG or MBISG is a more specialized and customized version that was specifically designed to improve the measurement of race and ethnicity in Medicare data. And it uses name and address information, but it uses a lot of other things that are available in CMS data, and it customizes to what we know about Medicare beneficiaries. So this data is regularly calculated for all Medicare beneficiaries, and there's an ongoing process regarding making these data available via the CCW, and for now these data may be available from CMS via a data use agreement. Next slide, please. So the context of the current work is trying to better understand CMS administrative race and ethnicity data. So the MBISG was developed because the Office of Minority Health within CMS was interested in comparing HEDIS clinical quality of care measures by race and ethnicity. And the original CMS administrative race and ethnicity data comes from the Social Security Administration, and anyone who last filled out a Social Security card before 1980 was only offered the options of Black, white, or other. And so while on the one hand, for those beneficiaries, it's whether somebody said, it's quite accurate in measuring whether somebody identifies as Black or not as compared with contemporary self-report. But as you might expect, it often undercounts people who, when asked, identify as Asian, Pacific Islander, Hispanic, and often it misclassifies people as white who would prefer to self-identify otherwise. And so we developed a Medicare-specific approach to use name, address, and other information to try to make this variable match what people say in self-report as closely as possible, so that we could take other things like HEDIS measures of quality of care and compare them as accurately as possible using race and ethnicity. And part of this approach involved taking this pre-existing name and address approach called the BISG and adapting it for the Medicare context. Next slide, please. And so just to illustrate what I was describing before, this chart shows you the correspondence between this Social Security variable, which is in the columns, and self-report, which is in the rows. And just to take an example, if if CMS, for somebody who self-reports being Hispanic, so in the third row, there's only a 30% chance that the SSA variable will record that person as being Hispanic, and there's a 58% chance that they'll be misclassified as non-Hispanic white. And so you can see there are sort of a number of challenges here with that. This is some of the motivation for undertaking this work. Next slide, please. I'll first describe the general BISD approach. So what this does is it uses information from the census, information about linkages between people's last names and the race and ethnicity they report on the census forms, and also linkages with the residential address. And what it does is it calculates the probability that a given person identifies as one of 6 different racial and ethnic groups based on those 2 bits of information. And we've done validation studies which have assessed the accuracy of this approach, and the basic name and surname address approach has high concordance for 4 groups: Asian Pacific Islander, Black, Hispanic, and white. And it's generally not recommended yet for American Indian, Alaska Native, and multiracial groups. And then there's a more specialized version, the Medicare BISG, that does require additional data. It requires Medicare administrative data, not just name and address, and it does better still by using that additional information for those 4 largest groups, and it's also showing promise for American Indian and Alaska Native beneficiaries as well. Next slide, please. So just to give you a sense of how this works, each decennial census, the Census Bureau puts together a list of surnames and cross-tabulates that with people's self-reported race and ethnicity. And they haven't yet done this for Census 2020. So this shows information for Census 2010. And they publish this for every name shared by at least 100 people in the U.S. And there are typically about 150,000 such names, and about 1 person in 10 has a less common surname. And although I won't go into it here, we also have methods for dealing with that. And just to take an example, if your surname is Williams, which is the 3rd most common surname in the U.S., there's roughly a 49% chance that you self-report as being white, and there's roughly a 47% chance that you self-report as being Black, and then all the other probabilities are much less. And that's quite different, for example, than if your surname were Miller, in which case it's much less likely that you identify as being Black, or if your surname were Garcia, say, in which case there's more than a 90% probability that you would identify as being Hispanic. So there's a lot of information in surnames that can be used. Next slide, please. The other thing we do is we look at the racial and ethnic distribution of the block group in which you live. And a block group is a relatively small geographic area. It's smaller than a census tract, for example. And that's a second source of information. And this is based on geocoded information corresponding to residential address using something called FIPS codes. Next slide. And the basic approach here is to use Bayes' theorem to combine these 2 information sources. What are the different probabilities of race and ethnicity based on your last name, what are the different probabilities based on where you live, and combine those in a way that integrates that information. And so, for example, in this slide, a given person might have a 21% predicted probability of being white, a 68% predicted probability of being black, and so on, with those 6 probabilities summing to 100%. Next slide, please. And so what you can do with this is for each person in the list, you can sort of look all this up and generate a series of probabilities. Next slide, please. So that's the basic version that just uses name and address. I'd like to say a little bit more about the version that's specialized for Medicare. And so, first of all, we have one of the information sources that we have is that original Social Security variable. And while it's not that accurate by itself, it does contain a lot of information. And in particular, it's quite accurate with whether a beneficiary will self-report non-Hispanic Black race and ethnicity. And so the first thing that we do is we take the name and address information, we take that Social Security Administration, and we roll those 3 things together. But then we also pull in other administrative information from CMS files and are able to improve the accuracy further. Next slide, please. So one of the ways that we validate this is there's a large national series of surveys called Medicare CAP surveys, which survey Medicare beneficiaries of all coverage types about their experiences with care. And you also, beneficiaries are also asked to self-report their race and ethnicity on the survey, and almost all of them do. Well, we can link that to the predictions that we make in order to see how accurate they are. And we do this using a method called cross-validation. And the gist of that is that the data that's being used to run the model isn't the same data that's being used to check the predictions. Next slide, please. So here is just an illustration of the accuracy that you get using the MBISG, which is the yellow bars, and the original Social Security variable, which is the blue bars. And this is what's called a concordance statistic, where 0.5 at the bottom means chance, and 1 at the top means it's perfect. And what you can see, and generally speaking, 0.7 is considered acceptable, 0.8 is considered good, and 0.9 is considered excellent. So you can see that by itself, the original variable is excellent for black versus not black. It's good for white versus not white. It's acceptable for API versus not, and it's not even that for Hispanic versus not. But the approach improves the performance for each of those categories. Only a little bit for the black race and ethnicity category because it's so close to perfect already, but substantially for the other categories, so that they're all well into the excellent range. Next slide, please. And now I'd like to just talk about a couple of applications. So often people think that these probabilities are an intermediate product, and that the goal is to classify individual people, and you don't have to. And in a lot of ways, we've designed this to help you compare groups rather than make statements about individual people. Where possible, we prefer to only make statements about individual people when they've directly self-reported information to us. But pretty much anything that you could do with self-reported data, you can do with these probabilities at a group level. So, for example, you could answer questions like, what's the racial and ethnic distribution of enrollment in a given plan or in a given state or overall. You could answer questions like, for each of several racial and ethnic groups, what proportion were screened for colorectal cancer? You can run regression models where you, for example, might ask, what are differences in costs or spending associated with race and ethnicity after controlling for other variables? And although we do encourage the use of the probabilities, we also produce a form of these data that do use individual classifications when they're wanted. Next slide, please. Just as an example to visualize this, if you want to estimate how many members of a given group are in, say, a plan, you can just add up the probabilities to get an estimated count, or you can average the probabilities to get a proportion. Next slide, please. Now I'll just be talking about a couple of research papers. In one study, we were interested in trying to understand voluntary disenrollment from Medicare plans, and this required having, and how that differed by race and ethnicity, and this required having an accurate measure of race and ethnicity, so we used the approach that I described here. In the first column, you can see that what the different rates of voluntary disenrollment were by race and ethnicity. They were much higher, for example, for Hispanic than non-Hispanic white beneficiaries. In the second column, we put other variables in the model. For example, when you can voluntarily disenroll depends on a lot of factors, such as whether you're duly eligible for Medicaid. And so when we account for those factors, then you see some adjusted differences by race and ethnicity as well. Next slide, please. So here in a second application, we were interested in trying to understand who doesn't answer the item at the end of the CAHPS survey about race and ethnicity. And so what we do here is we look just at the people who didn't answer that item, and then we link them to these racial and ethnic probabilities. And so in the first column, we found that that in turn allows us to estimate what percent of different beneficiaries by race and ethnicity chose not to answer that item. And we did find some evidence in the first column that Black beneficiaries were more likely to not answer that item 6.6% of the time than white beneficiaries 3.2% of the time, with Hispanic and API beneficiaries in between. And then we were also able to see how much of that was due to ending the survey before one got to the end versus specifically skipping around that item and answering ones afterwards. Next slide, please. So the third application here has to do with a health equity summary score, which is something that NCQA and RAND developed for CMS to try to measure and incentivize better care for underserved beneficiaries. And it uses both HEDIS and CAHPS data, and it particularly targets care for those who are dually eligible for Medicare and Medicaid, or who are LIS, as well as beneficiaries who are API Black or Hispanic. And it allows you to look at, for each Medicare plan, the current level of care, the extent to which the plan has improved over time, and in terms of closing gaps with its lagging groups, and also the extent to which, in an absolute sense, it's improved the care for each of these groups. And it links to this method in that this method allows the comparisons that involve race and ethnicity with HEDIS data. So the fourth application is very much related to the third application, and this is the idea that for HEDIS data, and this was really the original motivating application, the HEDIS data can be reported by race and ethnicity at the national level, and also for MA contracts. And in fact, for a number of years, this data has been available on the Office of Minority Health section of CMS's website. You can see the link here. And so, for example, one might be interested in questions like, in addition to how well a given contract performs overall, for say colorectal cancer screening, you can look up what plans perform the best and what plans perform less well, for example, for Black beneficiaries or Hispanic beneficiaries for colorectal cancer screening. The fifth application is one that's described in a journal article from a couple years back, and here we were particularly interested in the question of whether quality of care differed for API Black, Hispanic, and non-Hispanic white Medicare beneficiaries. And in addition to that, we wanted to understand the extent to which any inequities reflected concentration in higher or lower performing contracts versus different experiences in the same contracts. Next slide, please. And so here's an example of that analysis. So in this chart, these are showing differences between Black, Hispanic, and API beneficiaries and white beneficiaries. And when the bar goes to the left, that means that the group corresponding to the bar is receiving worse care. And when it goes to the right, it means that group is receiving better care. And so here we found a number of differences. In particular, antidepressant medication management was considerably, which are those first two bars, was considerably worse for Black, Hispanic, and API beneficiaries relative to non-Hispanic white beneficiaries, whereas patterns differed for some of the other behavioral health measures. Next slide, please. And then here, we looked just at the differences within the same contracts. And I'm so sorry. And you can see that this graph looks a lot like the previous one. In other words, the patterns that we see overall are largely concentrated in the same contract. So it's not, for example, that Asian, Black, and Hispanic beneficiaries are primarily enrolled in contracts that do a poor job on antidepressant medication management. Rather, it's that they're receiving worse care by those measures in the same contracts than non-Hispanic white beneficiaries. And so this again is just an example of the sort of comparisons that you can make using this data. And so just to echo what was said at the start. To the extent that there's interest in using BISG by HICN, this may be obtainable from CMS via the UA. There's a process that's in place, and to some extent, I and my colleagues may be able to help advise on the use of these approaches. And if you're interested in some of the work that was sort of briefly described here, there are also some journal articles that describe some of this work in greater detail. And here's contact information for me and CMS colleagues, several of whom who oversee this work, several of whom are on the call.